Hemorrhagic stroke is the deadliest type of stroke, killing approximately 40% of patients within the first 30 days, despite the most aggressive emergency medical and surgical treatment available in modern comprehensive stroke centers equipped with cutting-edge technology and 24/7 specialized neurosurgical teams. Unlike ischemic strokes, which are caused by blood clots blocking arteries and cutting off blood supply to brain tissue, hemorrhagic strokes occur when blood vessels rupture and bleed directly into brain tissue or into the subarachnoid space surrounding the brain. The accumulated blood creates rapidly increasing pressure within the rigid, confined space of the skull, compresses and damages vital brain structures controlling consciousness and life-sustaining functions, and directly damages neurons through the toxic effects of blood breakdown products and intense inflammatory responses triggered by blood outside vessels where it doesn't belong. Without immediate emergency treatment, including aggressive blood pressure control to prevent continued bleeding and hematoma expansion, urgent reversal of anticoagulation, if present, using specific reversal agents or blood products, and often emergency neurosurgical intervention to evacuate blood clots and relieve dangerous intracranial pressure, brain herniation occurs. Brain herniation is the catastrophic process where increasing intracranial pressure forces brain tissue through natural openings in the skull, including the foramen magnum at the skull base, compressing the brainstem, which contains vital centers controlling breathing, heart rate, blood pressure, and consciousness. Once herniation occurs and brainstem compression develops, death is almost inevitable despite the most aggressive interventions, including emergency decompressive craniotomy, where large portions of skull are removed to allow swollen brain tissue to expand outward. What makes hemorrhagic strokes particularly terrifying and devastating in seniors over 60 is that the risk increases exponentially and dramatically with advancing age due to multiple interconnected physiological and pathological factors that accumulate over decades of life. Chronic hypertension, affecting over 70% of adults over 60 in the United States, according to National Health and Nutrition Examination survey data, progressively weakens arterial walls throughout the brain over decades through a degenerative process called lipohyalinosis, where the muscular arterial walls become thickened, fibrotic, stiffened, and increasingly prone to spontaneous rupture. Cerebral amyloid angiopathy, where abnormal amyloid beta protein deposits progressively accumulate in the walls of small and medium-sized blood vessels, making them extremely fragile, affects 30 to 40% of adults over 70 and over 60% of adults over 80. The widespread use of anticoagulant medications, including warfarin and newer agents like apixaban and rivaroxaban, as well as antiplatelet medications, including aspirin and clopidogrel, prevents normal blood clotting mechanisms, allowing uncontrolled bleeding when vessels rupture. Research published in the journal Stroke examined age-specific hemorrhagic stroke incidence rates and mortality outcomes. Studies found that hemorrhagic stroke incidence increased from approximately 10 cases per 100,000 person years in adults aged 45 to 54 to over 150 per 100,000 in adults over 85. The case fatality rate also increased dramatically with age, exceeding 60% in adults over 80 compared to 30% in adults under 60. As stroke neurologists and neurosurgeons who have treated thousands of hemorrhagic stroke patients over 40 years of combined practice, we've learned that hemorrhagic strokes don't always present with sudden dramatic collapse. Many begin with subtle warning signs, hours or even days before the major hemorrhage. These early warnings represent sentinel bleeds, gradually accumulating blood or mass effect before global pressure increases. The tragedy we witness repeatedly is patients dismissing early symptoms as minor problems, delaying care until collapse occurs. In this video, we'll examine 8 critical early warning symptoms appearing before catastrophic hemorrhage. Understanding these warnings and calling 911 immediately is literally the difference between life and death. Symptom number 8. Sudden severe abdominal pain and repeated vomiting completely unrelated to eating or gastrointestinal function. Symptom number 8, perfectly aligned with the thumbnail image showing the abdominal region highlighted indicating severe pain, is sudden severe abdominal pain accompanied by nausea and repeated forceful vomiting that appears completely unrelated to what you've eaten, when you ate, any bowel symptoms, or typical gastrointestinal illness patterns. This counterintuitive and shocking symptom occurs in hemorrhagic stroke through a specific neurological mechanism that most people never suspect: brainstem compression from posterior fossa bleeding causing malfunction of the dorsal motor nucleus of the vagus nerve, which provides parasympathetic innervation controlling the entire gastrointestinal tract from the lower esophagus through the stomach, small intestine, and proximal colon. As increasing intracranial pressure progressively compresses the medulla, the vagal nucleus begins malfunctioning, sending completely aberrant and chaotic signals throughout the gastrointestinal tract, causing severe symptoms that perfectly mimic acute gastrointestinal emergencies. This neural malfunction causes sudden onset of severe nausea that doesn't respond to usual remedies like ginger, crackers, or positioning changes, repeated forceful vomiting that may be projectile in nature, shooting several feet, and severe cramping abdominal pain that patients describe as the worst abdominal pain they've ever experienced, worse than appendicitis, kidney stones, or gallbladder attacks they may have had previously. The pain is typically diffuse throughout the entire abdomen rather than clearly localized to a specific quadrant. The pain is constant or comes in severe waves, but never completely resolves between waves. Critically, the pain and vomiting don't relate temporally to eating. They occur regardless of whether you've eaten recently, and eating doesn't worsen or improve symptoms. These critical neurological signs include severe occipital or posterior neck headaches that the patient hadn't emphasized as their main complaint because the abdominal pain was more prominent. Mild progressive drowsiness or lethargy, where the patient keeps closing their eyes or falling asleep during examination. Subtle gait instability with wide-based ataxic gait when attempting to walk to the bathroom for urine sample. Slight slurring of speech called dysarthria, or double vision when looking in certain directions. Any of these neurological findings should immediately prompt brain imaging rather than continued focus on gastrointestinal causes. Research published in the journal Neurosurgery, specifically examining presenting symptoms of posterior fossa hemorrhages, including cerebellar hemorrhage and brainstem hemorrhage across multiple comprehensive stroke centers, found that nausea and vomiting severe enough to be chief complaints occurred in 60 to 80% of cases as initial presenting symptoms, often appearing hours before severe headache, altered level of consciousness, or other obvious neurological signs develop that would clearly indicate brain pathology. Abdominal pain severe enough to prompt extensive gastrointestinal evaluation, including abdominal CT scanning, occurred in 30 to 40% of posterior fossa hemorrhages, with many patients initially diagnosed with gastrointestinal conditions before brain imaging revealed the true diagnosis. Symptom number 7, sudden severe shoulder, neck, or arm pain that wakes you from sleep or prevents sleep entirely. Symptom number 7, dramatically and accurately depicted in the thumbnail image showing a woman lying in bed clutching her painful shoulder and upper arm with obvious distress on her face, is sudden onset of severe pain in the shoulder, posterior neck, or arm that appears without any trauma, injury, or obvious musculoskeletal cause, and is severe enough to wake you abruptly from sleep in the middle of the night or prevent you from falling asleep entirely despite exhaustion. This particular symptom pattern indicates subarachnoid hemorrhage, bleeding into the subarachnoid space between the brain surface and the arachnoid matter membrane covering it, most commonly from rupture of a cerebral aneurysm located on arteries at the base of the brain, or less commonly from arteriovenous malformation rupture, trauma, or bleeding disorders. The subarachnoid space normally contains only cerebrospinal fluid circulating around the brain and spinal cord, providing cushioning and removing metabolic waste products. When arterial blood under high pressure suddenly enters this space from aneurysm rupture, it spreads rapidly through the cerebrospinal fluid pathways, traveling around the entire brain surface, down along the brainstem, and into the spinal subarachnoid space surrounding the cervical, thoracic, and even lumbar spinal cord. The mechanism producing severe neck, shoulder, and arm pain involves blood directly irritating extremely pain-sensitive structures, including the meninges, particularly the dura mater, which has extensive pain innervation, major arteries at the base of the brain, including the circle of Willis, which contains pain receptors in arterial walls, and critically, the cervical nerve roots exiting the spinal cord in the neck region and traveling to shoulders and arms through the brachial plexus. When blood spreads down into the cervical spinal subarachnoid space surrounding the spinal cord and nerve roots, it directly contacts and intensely irritates these nerve roots, causing severe radiating pain that travels along the nerve distribution into shoulders, upper arms, and sometimes all the way down to hands and fingers. The blood acts as a severe irritant, triggering intense inflammatory responses and activating pain receptors throughout the affected areas. Many patients experiencing sentinel bleed from aneurysm, which is a small warning leak of blood from the aneurysm before catastrophic major rupture occurs, present to medical care with sudden severe neck pain that radiates into one or both shoulders and down the arms in specific nerve distribution patterns. Tragically, only approximately 30% of patients experiencing these sentinel warning symptoms actually sought immediate emergency medical attention. The remaining 70% either didn't seek medical care at all, attributing symptoms to minor musculoskeletal problems that would resolve spontaneously, or sought care from primary care physicians or urgent care centers where symptoms were misdiagnosed as cervical spleen problems, muscle problems, or other benign conditions. Among those patients who did seek emergency department care for sentinel symptoms, the symptoms were correctly diagnosed as possible subarachnoid hemorrhage, requiring brain imaging in fewer than 25% of cases. Symptom number 6. Sudden, severe thunderclap headache, described as the worst headache of your entire life. Symptom number 6 is the classic warning sign that everyone should know from public stroke awareness campaigns, but that many people still tragically ignore or misinterpret. Sudden, severe headache reaching maximum intensity within seconds to 1 minute, described as thunderclap headache or the worst headache of your entire life, worse than any migraine, tension headache, or other headache you've ever experienced. This distinctive symptom indicates acute hemorrhage, most commonly subarachnoid hemorrhage from ruptured cerebral aneurysms, but can also occur with intracerebral hemorrhage bleeding directly into brain tissue, subdural hemorrhage bleeding between dura and brain surface, or other forms of intracranial bleeding. The pain character is absolutely distinctive and unlike other headache types. It reaches maximum intensity almost instantaneously, within seconds to 1 minute, rather than building gradually over minutes to hours like migraine or tension headaches. The onset is so sudden and dramatic that patients can tell you exactly what they were doing when it started: sitting at dinner, getting out of bed, exercising, or having a bowel movement where straining increased intracranial pressure, triggering aneurysm rupture. The intensity is extreme, typically rated 10 out of 10 on pain scales, described as being struck by lightning, hit in the head with a baseball bat, having a bomb explode inside the skull, or having the worst pain imaginable. Many patients describe it as feeling like their head is literally splitting open or exploding from inside. The pain location is typically diffuse, affecting the entire head, though sometimes it's more concentrated in specific regions. Subarachnoid hemorrhage from ruptured posterior circulation aneurysms on basilar or vertebral arteries often causes severe occipital and posterior neck pain. Anterior circulation aneurysm rupture on anterior or middle cerebral arteries may cause more frontal or temporal pain, but regardless of initial location, the pain typically spreads to involve the entire head within minutes as blood spreads through cerebral spinal fluid pathways around the entire brain. The mechanism producing such severe pain involves blood under arterial pressure suddenly entering the subarachnoid space and intensely irritating multiple pain-sensitive structures, including the dura mater, which has extensive pain innervation from trigeminal nerve branches, major cerebral arteries, which have pain receptors in their walls, and the brain surface itself, where blood causes intense inflammatory responses. Blood is extremely irritating to tissues where it doesn't belong, triggering massive release of inflammatory mediators and direct activation of pain pathways. Research published in the journal Stroke, examining headache characteristics in various types of hemorrhagic stroke, found that sudden, severe thunderclap headache was present as the presenting symptom in 80 to 90% of subarachnoid hemorrhage patients, 50 to 60% of intracerebral hemorrhage patients, particularly those with lobar hemorrhages near brain surface, and over 90% of patients with posterior fossa hemorrhages in cerebellum or brainstem. The sudden onset reaching maximum intensity within 1 minute and the extreme severity rated 10 out of 10 were highly specific characteristics for hemorrhage, distinguishing it from other headache types. Yet despite these distinctive features and extensive public education campaigns teaching people to recognize thunderclap headache as a medical emergency, studies examining patient responses and time to seeking care found that 30 to 40% of patients experiencing thunderclap headache delayed seeking medical care for hours, taking over-the-counter pain medications like acetaminophen or ibuprofen and hoping the headache would resolve spontaneously. Some patients went to bed hoping to sleep off what they assumed was just a severe migraine. Others assumed it was the worst tension headache they'd ever had, attributing it to stress or neck muscle tension. By the time they finally sought medical care, often because the headache didn't improve or other symptoms developed, including vomiting or altered consciousness, critical hours had passed during which rebleeding from ruptured aneurysm may have occurred, dramatically worsening outcomes. Symptom number 5, sudden nausea and repeated vomiting without any accompanying diarrhea, fever, or other gastrointestinal symptoms. Symptom number 5 is isolated severe nausea and repeated vomiting without any accompanying diarrhea, fever, abdominal cramping, or other gastrointestinal symptoms that would suggest viral gastroenteritis, food poisoning, or other primary gastrointestinal illness. This symptom pattern indicates increased intracranial pressure from accumulating blood within the rigid skull, causing pressure on the vomiting center located in the medulla oblongata of the brainstem. As blood accumulates from hemorrhage, whether intracerebral hemorrhage bleeding into brain tissue, subarachnoid hemorrhage spreading through cerebral spinal fluid, or intraventricular hemorrhage filling the fluid-filled ventricles deep in the brain, the total volume inside the rigid skull increases. Because the skull is a fixed, closed space, this increased volume translates directly into increased pressure. Normal intracranial pressure is 5 to 15 millimeters per mercury. As hemorrhage progresses, pressure can rise to 20, 30, 40 millimeters per mercury or higher. When intracranial pressure exceeds certain thresholds, the vomiting center or chemoreceptor trigger zone in the medulla oblongata is stimulated, causing sudden, severe nausea and forceful vomiting. The vomiting from increased intracranial pressure has characteristic features that distinguish it from gastrointestinal causes if you know what to look for. The vomiting is often projectile, meaning it shoots out forcefully several feet rather than just flowing out of the mouth. It occurs suddenly without the prolonged nausea that typically precedes vomiting from gastrointestinal causes. It brings absolutely no relief of nausea. Patients with gastroenteritis typically feel temporarily better after vomiting, but patients with increased intracranial pressure continue feeling severely nauseated despite repeated vomiting. The vomiting is not associated with diarrhea, which is almost always present in viral gastroenteritis. There's no fever unless the hemorrhage causes hypothalamic dysfunction affecting temperature regulation. There's no clear relationship to eating. Vomiting occurs whether or not food has been consumed recently. Symptom number 4. Progressive drowsiness and difficulty staying awake despite having adequate sleep the previous night. Symptom number 4 is progressive drowsiness, lethargy, and difficulty staying awake that develops over hours and progressively worsens. This ominous symptom indicates that hemorrhage is expanding and intracranial pressure is rising toward critical levels, or that herniation is beginning to compress the reticular activating system in the brainstem responsible for consciousness and wakefulness. As hemorrhage expands, intracranial pressure rises progressively. When pressure reaches 20 to 25 millimeters mercury, cerebral blood flow begins to decrease because cerebral perfusion pressure, calculated as mean arterial pressure minus intracranial pressure, falls below optimal levels. When pressure exceeds 30 to 40 millimeters mercury, global brain perfusion becomes significantly impaired. The reticular activating system, a network of neurons in the brainstem that maintains wakefulness and alertness, is particularly sensitive to decreased perfusion and direct compression. As this system malfunctions, patients become progressively drowsy. The drowsiness progresses through predictable stages. Initially, patients seem a bit sleepy, closing their eyes frequently during conversations. They yawn repeatedly. They drift off during activities that normally wouldn't cause sleepiness, like watching television or sitting at dinner. Family members might comment that they seem unusually tired. As pressure continues rising, drowsiness progresses to lethargy, where patients sleep unless actively stimulated and are slow to respond when awakened. Further progression leads to stupor, where only painful stimulation produces arousal, and finally to coma, where no stimulation produces meaningful response. This progressive decrease in level of consciousness is one of the most ominous signs in hemorrhagic stroke. It indicates that brain herniation is imminent or already occurring. Yet family members often don't recognize the extreme danger, assuming their loved one is just tired, had a long day, isn't feeling well, or is recovering from the headache they had earlier. They allow them to go to bed and sleep, not realizing that herniation is progressing toward irreversible brainstem damage and death. Research examining predictors of outcome in hemorrhagic stroke found that decreased level of consciousness at presentation was the single strongest predictor of poor outcome and mortality. Patients who were drowsy or lethargic at presentation had 3 to 4 times higher mortality rates than those who were fully alert. Those who were stuporous or comatose had mortality rates exceeding 70 to 80% even with aggressive treatment. Symptom number 3, sudden difficulty walking, loss of balance, or incoordination that appears over minutes without obvious cause. Symptom number 3, the symptom most commonly ignored and dismissed as unrelated to stroke, is sudden difficulty walking, loss of balance, clumsiness, or incoordination appearing over minutes to hours. This symptom indicates cerebellar hemorrhage, bleeding into the cerebellum at the back of the brain, which coordinates all voluntary movements and maintains balance and posture. The cerebellum is located in the posterior fossa at the base of the skull, positioned behind the brainstem. Despite being only 10% of brain volume, it contains over 50% of all brain neurons. It's responsible for coordinating and fine-tuning all voluntary movements, maintaining balance and posture through constant adjustments, coordinating eye movements, and enabling smooth execution of learned motor sequences. When hemorrhage occurs in the cerebellum, these critical functions are disrupted. Patients suddenly cannot walk normally, staggering and veering unpredictably to one side then the other, like someone severely intoxicated. They lose balance easily when standing still, swaying and catching themselves on furniture or walls. Walking requires touching walls for support. They cannot walk in a straight line. Turning while walking is particularly difficult and dangerous, requiring multiple small steps and often causing falls. Fine motor tasks become clumsy and incoordinate. Handwriting becomes large and shaky. Picking up small objects becomes difficult. Drinking from a cup causes spilling. The critical feature distinguishing cerebellar hemorrhage from other causes of walking difficulty is that weakness is usually completely absent. Patients have normal strength when tested individually. They can push and pull with normal force. Speech is typically normal or only mildly slurred. Sensation is normal, yet despite normal strength, they cannot walk or coordinate movements properly. This dissociation between normal strength but profound incoordination is characteristic of cerebellar pathology. Yet because weakness, speech problems, and other obvious stroke symptoms are absent, 90% of patients and families don't recognize this as stroke. Research found that patients with cerebellar hemorrhage causing ataxia initially attributed symptoms to inner ear problems like vestibular neuritis, benign positional vertigo causing dizziness, generalized weakness from illness, or simply losing balance from aging. Most delayed seeking medical care for hours or even days, assuming symptoms would improve spontaneously or could be addressed with non-urgent outpatient evaluation. Symptom number 2, sudden focal weakness or numbness affecting one side of the body, including face, arm, or leg. Symptom number 2 is sudden weakness, numbness, heaviness, or clumsiness affecting one side of the body, including the face, arm, or leg. While this symptom is well known and widely recognized as indicating stroke from public awareness campaigns teaching fast assessment, face drooping, arm weakness, speech difficulty, time to call 911, many people don't realize that hemorrhagic stroke causes these identical symptoms just as commonly as ischemic stroke, and distinguishing the type requires brain imaging. The weakness develops suddenly over seconds to minutes, affecting the arm, leg, or face on one side of the body. The pattern depends on hemorrhage location. Hemorrhage is in or near the internal capsule where motor nerve fibers descend in a tightly packed bundle from cortex to brainstem and spinal cord, cause weakness affecting the entire opposite side, including face, arm, and leg. Cortical hemorrhages in motor cortex cause weakness in more limited distributions depending on exactly which area of cortex is damaged. Brainstem hemorrhages cause complex patterns, including weakness affecting both sides or crossed patterns with face weakness on one side and body weakness on the opposite side. The mechanism involves hemorrhage directly destroying brain tissue where motor nerve fibers travel or causing mass effect compressing these pathways. As bleeding expands over minutes to hours, weakness progressively worsens from mild clumsiness to moderate weakness to complete paralysis if hemorrhage continues enlarging without intervention. Blood accumulation also causes surrounding brain edema or swelling, further compressing motor pathways and worsening weakness even without additional bleeding. Research examining clinical presentations of intracerebral hemorrhage found that sudden unilateral weakness was present in 60 to 70% of cases at initial presentation, making it the most common presenting symptom. The weakness severity ranged from mild, where patients could move the affected limb but with reduced strength, to moderate, where limb movement was possible against gravity but not against resistance, to severe, where no movement was possible. What distinguishes hemorrhagic stroke from ischemic stroke clinically is extremely difficult or impossible without brain imaging, as both cause identical sudden focal neurological deficits. However, certain features are more suggestive of hemorrhage. Hemorrhagic stroke more commonly causes severe headache at symptom onset, occurring in 50 to 60% of intracerebral hemorrhages versus only 10 to 20% of ischemic strokes. Nausea and vomiting are more common in hemorrhage. Symptom number 1. Sudden visual changes, including double vision, sudden vision loss in one or both eyes, or visual field defects. The number 1 most sensitive early warning symptom, appearing in the majority of hemorrhagic stroke patients hours to days before other symptoms develop, but frequently dismissed as unrelated eye problems, is sudden visual changes manifesting in several distinct patterns. These include double vision, called diplopia, where you see 2 images of every object. Sudden vision loss in one eye, called monocular vision loss, where one eye goes blind. Sudden vision loss in both eyes, called binocular vision loss, or visual field defects, called hemianopia, where you lose vision in one half of your visual field in both eyes simultaneously, as if half the world has disappeared. The mechanism and significance differ by symptom type. Double vision indicates brainstem hemorrhage, affecting cranial nerves controlling the 6 extraocular muscles that move each eye in coordinated fashion. The 6th cranial nerve, or abducens nerve, controlling the lateral rectus muscle that moves the eye outward, is particularly vulnerable to compression from any cause of increased intracranial pressure. 6th nerve palsy causes horizontal double vision, where images are side by side. 4th nerve or trochlear nerve palsy causes vertical or diagonal double vision. 3rd nerve or oculomotor nerve palsy causes complex double vision patterns, plus eyelid drooping and pupil dilation. Research examining visual symptoms across all types of hemorrhagic stroke found that visual complaints of any type occurred in 20 to 30% of patients as presenting or early symptoms. Double vision was most common in posterior fossa hemorrhages, affecting the brainstem where cranial nerve nuclei are located. Visual field defects occurred most commonly in lobar hemorrhages, affecting occipital or parietal lobes. Sudden vision loss, indicating optic nerve compression from increased pressure, was an ominous sign associated with large hemorrhages and poor outcomes. Critically and tragically, studies found that approximately 30% of hemorrhagic stroke patients experienced visual symptoms as initial warning signs, appearing hours to days before other symptoms or major hemorrhage expansion occurred. Patients who recognized these visual warnings as neurological emergencies and sought immediate care underwent emergency brain imaging, had hemorrhages detected early while still small, and received urgent treatment including blood pressure control and neurosurgical evaluation when appropriate. These patients had dramatically better outcomes with lower mortality and less disability than those who delayed seeking care. However, many patients experiencing sudden visual changes assumed they were having eye problems requiring routine ophthalmology evaluation rather than neurological emergencies. They assumed sudden double vision meant they needed new glasses or had cataract progression. They thought visual field loss meant they needed stronger prescription. They scheduled routine ophthalmology appointments weeks in the future. Some tried closing one eye to eliminate double vision or adjusting their glasses, hoping vision would improve. Meanwhile, the hemorrhage continued, slowly expanding. Intracranial pressure progressively increased, and eventually other symptoms developed, forcing emergency evaluation, by which time critical hours or days had passed during which intervention could have prevented deterioration. What you absolutely must do is call 911 immediately for any sudden visual changes, including double vision where you suddenly see 2 images, sudden vision loss in one or both eyes, sudden loss of half your visual field in both eyes, or sudden blurred vision that doesn't clear with blinking. These are neurological emergencies, not eye problems requiring routine ophthalmology. Emergency CT scan detects hemorrhage. If hemorrhage is found causing mass effect in critical locations like posterior fossa or showing signs of expansion, emergency neurosurgical intervention may be life-saving. These 8 early warning symptoms of hemorrhagic stroke in seniors demand immediate recognition and emergency response: abdominal pain with vomiting, severe shoulder or neck pain, thunderclap headache, isolated vomiting, progressive drowsiness, walking difficulty, sudden weakness, and sudden visual changes all indicate hemorrhage requiring emergency intervention. Minutes and hours matter critically in hemorrhagic stroke. Early detection allows blood pressure control, preventing rebleeding, anticoagulation reversal, preventing hemorrhage expansion, and when necessary, emergency neurosurgery to evacuate blood clots and relieve pressure, dramatically improving survival and functional outcomes. Which symptom surprised you most? Have you or loved ones experienced any of these warnings? Share your experiences in comments below to help others recognize symptoms. If this information could save someone's life or prevent devastating disability, please share this video widely with family, friends, and social networks. Subscribe to our channel for more evidence-based, life-saving medical content that could protect you and those you love. Thank you for watching, and remember, when hemorrhagic stroke threatens, every minute counts.